Children with cystic fibrosis may have a lot of chronic rhinosinusitis, and this may put them at risk for obstructive sleep apnea. Especially if they are younger, then they are more likely to have obstructive sleep apnea. As they get older, this risk decreases a little bit, but they then have a lot of problems with sleep. They have decreased total sleep time, they have increased wakenings and wake after sleep, and also they have problems with gas exchange. So they may have lower oxygen saturation even if they have normal saturations during daytime, and they may also have increased levels of carbon dioxide. So having a decreased sleep time may put them at increased risk for additional problems, and this is really important for their overall health. Children with chronic lung disease have already problems with sleep, and they have decreased sleep times because they may have to do a lot of therapies, or they may wake up because of coughing. So if they have additional obstructive sleep apnea, this may further impair their sleep quality and impair their gas exchange. And we all know that even if you have just decreased sleep times, you're more likely to have problems with cognition, you're more likely to have obesity and metabolic syndrome. So if you have on top of it obstructive sleep apnea, then you are more likely to have problems with cardiac problems with your heart, such as pulmonary hypertension, and also problems with neurocognitive areas. So you may have more behavioral problems. So you're already at risk for behavior when you have a chronic lung disease. If you have an additional sleep problem or obstructive sleep apnea, this may further be impaired. So a lot of studies looked at children with obstructive sleep apnea and children with sleep problems who have chronic lung disease, and we tried to find ways to predict those. Unfortunately, except for using objective measures, it's almost impossible to detect nocturnal gas exchange abnormalities when these children are awake. Of course, one of the clues can be low saturation, and also if the child has impaired lung function. For example, if you have CF and your FEV1 is less than 80% predicted, then you may more likely have low saturations during sleep. But the best way to detect those is to use nighttime measures such as nighttime pulse oximetry, actigraphy, and also polysomnography. So one of the ways to approach to detect hypoxia is looking at the overnight pulse oximetry and of course polysomnography. Once you detect hypoxia, it's important to treat these children to improve their quality of sleep and also quality of life, and treat them with oxygen. If they have no abnormalities of their carbon dioxide exchange, you can try oxygen therapy, but we need to make sure that these children don't have increased hypoventilation, because oxygen therapy decreases the ventilation. So we need to carefully monitor gas exchange once we start them on oxygen, and aim oxygen levels that are a little bit lower than normal healthy children. So if the child has just obstructive sleep apnea, even with the chronic lung disease, and the child has adenotonsillar hypertrophy, of course the first approach is to remove those. But if there is no adenotonsillar tissue, or if the obstructive sleep apnea persists after adenotonsillectomy, then you may need to use either CPAP or non-invasive ventilation. But if the problem is just the gas exchange and you're not able to elevate this with just oxygen therapy because the kid has high carbon dioxide levels, then the best way to treat this is non-invasive ventilation. Non-invasive ventilation has been proved to be useful in a lot of areas of sleep in children with CF and improves the oxygenation a little bit better than just giving supplemental oxygen. So although it's a cumbersome therapy, it may improve the quality of sleep and quality of life of these children. So it's an important consideration. If the child needs it, it may improve a lot of health quality issues for these children.